You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way.
Hello, and welcome to another episode of Fertility Docs Uncensored. This is Dr. Carrie Bedient from the Fertility Center of Las Vegas, joined by my two delightful and cool and refreshed looking partners in crime, Dr. Abby Eblen from Nashville Fertility Center.
Hi, everybody.
And Dr. Susan Hudson from Texas Fertility Center.
Hello.
How are you both doing, and how come you look so cool and lovely and just delightful in this really freaking hot summer?
It is crazy hot this year. I got to go a little north this week, so that was fun.
Where'd you go?
I went to Chicago.
Was it cooler?
It wasn't cool. I mean, like it was in the high, like in the heat of the day, it was in the high 80s, low 90s, but in the evening it was nice.
Cooler than Texas, though?
Oh yeah, Texas is like crazy hot right now. I'm sure it's not as hot as Vegas is, but I think it feels more like mid to late July than late June, unfortunately. So, you know.
Chicago in the summertime is, I mean,
it's awesome.
It can be lovely, but it can also be brutally humid. And as a desert rat, I cannot handle that humidity. And it is the fastest thing to make me start whining on this planet.
Anything to you, Carrie, is human, because Las Vegas is like sets the bar for everybody else as far as humidity. So to me, when I go up there, I'm like, oh, this feels great.
Yeah, it was interesting. I didn't know that Chicago was actually built on a swamp. Did you know this?
I knew that. Yeah. A bunch of garbage. Yeah, I knew that.
Who knew?
I did not know that.
We went on the one of the riverboat tour things, that the architecture tour.
Oh, that's a good tour.
That is a good tour.
And I learned so much about, it being built on swamp and about the Chicago fire and how tall these skyscrapers are. And it's hilarious because like now that I've come back, like I look at every tall building and I'm like categorizing them according to era. I'm like, I am such the architecture aficionado after one riverboat tour.
Well, as an art history minor, one of the things we studied was buildings and how they looked and the style. So I loved that architectural boat tour. It was awesome.
It was fun. We had a good time. It was a quick trip. Flew up like Tuesday evening and flew back on Thursday. But
did you do a lot of shopping?
We did a little shopping. We went and turned in our paperwork to try to get our Lithuanian dual citizenship things.
Oh, wow.
So it was a first big step. They have to get the paperwork and then they send it. We went to the consulate. And it was hilarious because my mom was with me because she's applying as well. And, we go and do this thing it took us a couple of hours and we gave them all the paperwork, and then the paperwork gets sent to Lithuania and then they officially see if it fits all the categories that it has to and everything like that. And then we left. And so she was like, this kind of really like ruined my entire like vision of what I expected this to be like, because first of all, this is a consulate, not an embassy. Okay.
Oh, so this is like a tiny office, not someplace fancy.
This is an office in the Chicago NBC building. Okay. And so, it was still kind of cool, but she was expecting, like the iron gates and the guards and, when you run in there away from the bad guys in the movies.
She had like the Bourne Identity in mind as for what she was expecting.
That's funny.
Yeah. I was like, if this works, I was like, maybe we can go to the actual embassy, and guessing that's in DC.
Yeah.
And you can experience the full embassy thing.
Oh, that'd be cool. That'd be great.
And maybe as a special treat for your mom, you can hire some kind of fake hitmen to come chase you so that you can go running into the embassy and make it a full experience. Like, I'm sure there's a lot of actors out there who need a side gig for a day to chase you down, and you can be action movie stars.
It would be funny. But she's in her mid-70s. I wouldn't want her to have a heart attack because she thought she was getting chased by bad guys. So I probably won't do that. But it is a funny thought.
What'd you do this weekend, Abby? Anything fun?
So I took a few days off at the end of the week, and I like to paint. And so this woman who's like the rock star of watercolor painters, portrait painters, was in Huntsville, Alabama. So I spent 3 days in Huntsville, Alabama. And she also is unique because it took her 7 years to do it, but she painted a veteran in all 50 states and did like a watercolor portrait of all 50 veterans in 50 different states.
Mm-hmm.
And like whatever their job was. Like there was a guy that was like a falconer. And so she painted a picture of him with the birds. And there was a woman that was a truck driver. It was this great picture of her next to her rig. And there was a guy that was a coal miner. And these pictures are humongous and they were just breathtakingly beautiful. So the Huntsville Art Museum has those currently, and we'll have them for another month or so. And then they go to DC and hopefully will be permanently somewhere. So it was really fun to get some of her tips and take her class and then see her watercolors that she did that were breathtaking. So it was fun.
Cool.
That's really cool. You guys do such fancy things. I made a new cookie recipe this weekend.
That sounds yummy.
How do you come up with a new cookie recipe? How do you do that?
I didn't come up with it. I just went looking for
something that looked yummy.
And I made red raspberry frozen yogurt and a dark chocolate ice cream. And so I wanted something to go with them. And I figured, okay, almond is a good supplemental flavor.
Oh yeah. Almond cookies are always good.
And so I found this really chewy recipe that it's kind of based on macarons. I don't think I'm saying that right, but
no, yeah, I think you are.
It's that same meringue and almond flour, and it's really chewy. You let it sit out for a couple of hours to get that crust, and then you get the crackle and you roll it in sugar. So it's perfectly white, and then it's got these deep kind of light yellow clefts where the almond flour is making it yellow, and they're a little crispy on the outside and really chewy on the inside. They were really good full dessert with the raspberry yogurt and the chocolate ice cream.
Oh, that sounds delicious. One time because I really like almond cookies too. And I bought this almond paste with the intention, there's some cookie that you can make with the almond paste in the middle. And I bought the almond paste, but I never got around to making the cookie, but it sounded really good.
Almond paste is good enough. You don't need to make the cookie. Just eat the almond paste.
Just buy the spoonful.
Susan, do you have our question for the day?
I do have our question of the day. So our listener has been undergoing fertility care for a number of years. It started around August 2017. And they got a semen analysis that looked essentially normal. They decided that their path was going to be essentially 3 IUIs and then an IVF cycle. So they did 2 IUIs and then decided to go on to IVF. When they did IVF, they didn't quite get the result, didn't have quite the stimulation they were expecting to get. And did end up with a couple of embryos, transferred those embryos and did get pregnant, but baby stopped developing and ended up having to have a D&E and then went through some blood testing, looking for blood clotting disorders and this type of thing. And so essentially kind of after about 2 years of treatment, she decided to kind of step away from her job and they were going to do some more treatments. And I'm going to kind of, from this part, kind of read what she says. My husband convinced me to try again in spring of 2019. So we started to try again. The doctor said she was going to throw the kitchen sink at me. I was taking more meds at this time. I was taking CoQ10, avoiding receipts, perfume, plastics, nail salons, started to feel good again. And when they started to see how many eggs were growing, there were only 2 and there was only 1 to retrieve. They said maybe it was a bad month and they should convert to IUI. Patient agreed. My husband was not there and he was upset with that decision. I think just upset with the outcome. And when I pushed, he told me he was done with fertility treatments. He has been my biggest cheerleader and I knew I could not move forward knowing I did not have his 110% support. He left it up to me. So we did the IUI and stopped fertility treatments altogether. It was the hardest decision I ever made. She basically begged me not to give up and that she would waive the fees, but he already had his mind made up. We said we would foster or adopt, and I cannot seem to pull the trigger. I only think about doing fertility again, but if we do it again and it is not successful, we would not be able to afford adoption. We went to foster classes at the end of 2019, but I'm not sure if it is for me. Of course, 2020 was a wash due to COVID. I still wonder if that was the right decision and if we would ever be able to have a child of our own. I've been thinking about it a lot lately. I never felt good about how we stopped, and now I'm wanting to try again, but time has passed and I am now 35. I am not sure if it is a waste of my money and happiness to go down that road again. Any and all advice appreciated.
Wow.
Yeah.
That's a long question. Wow. Lots of information. What do you think, Carrie?
I mean, it sounds like the crux of the question is, what do I do when my partner and I are not on the same page?
Yeah, that's right.
That is something that we see very commonly. And what I hear in all of this is that she's been through a crap ton of treatment, had at least one that made it to the point of miscarriage, meaning egg sperm came together, they implanted, but something wasn't going right. And so the pregnancy stopped, which is in general, although it sucks to high heaven for the patient, is usually the right thing for the pregnancy. And so now they're at this crossroads where he's done and she's not. And I think at this point, there just has to be some ongoing discussion about it. Therapists are really great when it comes to something like this, because going to a therapist doesn't mean that there's something wrong. Therapists are to help communicate. And sometimes they can help bring things out and both acknowledge and accept the emotion as well as separate from it. Because anytime you bring up fertility, it is super emotional. And that means tears happen and angry words happen and feelings of despair and all of those things at the same time. And so what I would say at this point for you is probably sit down with a therapist, and you probably need 2 different types of therapy. One is with him. The other is just for you, because whatever decision you come to is going to be difficult, either because, he's not totally on board, or he is, or you're not on board, or you don't feel comfortable with it, whatever. And so sometimes there's a lot of value in therapy to help you make a decision and to feel comfortable with it and to cut through the crap that's going through your brain that is just bogging you down. So I would kind of tend to think that. And the other thing that strikes me about that is that the fertility doc said, I will help you get through this. That means she thinks that you got a chance. I mean, those offers are never made lightly, ever. And because it, as expensive as fertility treatment is, there's so many man hours and equipment and all the things that go into it, that if she's offering that, there's a chance there. So I don't know. That's kind of my blurb of ideas. What do you guys think?
I mean, my take on it is, I think there's an emotional aspect to it that you touched upon, and that's obviously got to be addressed with she and her husband. We can't ignore the fact that for most of our patients, it's a financial decision too. I mean, you only have so much money. And if you have X amount of dollars and you're thinking, well, gosh, maybe I'll adopt, but if I do this other fertility treatment, I may not have the money to adopt. I mean, it's certainly a gamble. And I guess my concern is, I agree the doctor said she would be willing to kind of help. But, I don't know, based on the way our patients or, our listeners stimulated, I think, unfortunately, the reality of it is, that's for a 35-year-old, getting only 1 or 2 eggs is not normal. I mean, typically, I would think we'd plan to see more like 10 or 15 eggs.
Well, I think that's what she got for embryos wise at the blastocyst stage. So she had a couple of blasts.
Oh, okay.
Well, no, but at the end, she said that they converted they only got 2 eggs.
That's true.
Right. Yeah. So I think there's an issue with poor stimulation. And I think it's, I've been through fertility too, and it's a tough decision to know what to do next. But, the reality of it is, our listeners just not stimulating the way you'd expect. And, if you only have X number of dollars, maybe if you really want to adopt and you've got to use that money to adopt, I mean, I think I would probably talk to the therapist about it. But I think, looking at it objectively and not emotionally, which I know is really hard to do, I think that sounds like that might be the better decision.
Yeah, I agree with both of you. I do want to say that also know that sometimes this might be a good time to get a second opinion. I mean, we've all seen people who went through stimulations with one set of doctors and then they come to see us and we're like, hey, we could do something a little bit different. So sometimes a fresh set of eyes, and sometimes partners are more open to a fresh set of eyes, at least to say, hey, is everything my other doctor did like in line with what you would expect? Because just because you get a second opinion doesn't mean you have to actually change doctors. It's just exactly that, getting a second opinion. The other thing to consider is if, your tie is not necessarily a biological child, but that you want to have pregnancy and things like that, that perhaps maybe considering something like donor egg or donor embryo, especially if you're thinking about adoption. Sometimes I have patients who find, especially donor embryo, a nice bridge. It's, not quite adoption, but because you get to control the pregnancy part of it, but you still have that adoptive kind of feel component, that maybe it might be time to kind of, you're not necessarily in line with his path that he's thinking. He's not in line with the path that you're thinking. Maybe y'all need to find a new path that kind of bridges the desires and comfort level of both of you. And again, that's where the therapist can really help out.
Yeah.
And maybe just sitting down and having a conversation of, hey, I'm not really comfortable with what you're thinking. You're not really comfortable with what I'm thinking. Let's think outside the box. And maybe one of these other ideas might be something that's going to give us a better chance of having a baby and having a child in our lives, that we can kind of move forward in that direction. So just some ideas.
Yeah, excellent. All right. So what we are talking about today is kind of feels like a weird topic in some respects.
It's a great topic.
But it's a great topic because we get these questions all the time.
It is a great topic. But when I think about all of the things we do, which are, okay, this is the testing we are going to do. This episode this is the testing we're not going to do.
Yeah, the testing that's obsolete.
Yes. And so we're just going to go through some of the most common ones that we see that are, that pop up a little bit more frequently because they were used in the not so distant past, or they were used in the distant past, but they have managed to maintain a life of their own and they just will not go away in the life of the internet.
Dr. Google.
Things never die on the internet. They never die on the internet. So be wary when you read something about a test on the internet.
Dr. Google went to a questionable medical school. So first test is the ever popular postcoital test. So Susan, can you describe how this really delightful, there's a lot of delightful tests that we do in the office.
I'm going to punt this one. I'm punting to Abby because I have personally never done a postcoital test.
I did this test. Oh man. So the postcoital test, the idea kind of makes sense. It's like, is the sperm, can it get through the cervical mucus? And so what you would do is the patient and her partner would have intercourse during the fertile window when the mucus was supposed to be thin and stringy. And so the patient would come in, I think it was within 24 to 36 hours of intercourse, about 12 hours of intercourse, they'd come in. And then basically you would take them back to the room and you would try, which was really challenging, to get cervical mucus. So sometimes you'd use forceps, or sometimes you'd use a little instrument to or like a little syringe to kind of suck up the mucus. And then the idea would be you would count how many sperm you saw per high-powered field. And depending on the number, you'd say, yes, the sperm's getting through, or no, it's not. Well, the thing about that, though, is you're looking at the cervical mucus. And so how do you know if the sperm that you're seeing there gets any further than where they were, when you looked at them? And, obviously for all kinds of reasons, sampling was not very good. And, it was not, there's no standardized way of looking at the mucus or getting the mucus. And so anyway, it was a test that probably was done, gosh, I don't know. It hadn't been done for a long time. I can't remember. Probably for 20 years, we've not done a postcoital test, I would say, probably. Because I think it's been at least 20 years.
I think that's a fair estimate.
That just sounds like such a great way to kill sex.
Yeah.
Here, ma'am, can you please do this and then come to our office? All right. So next test, clomiphene challenge test.
All right. So I'll take this one because I did do Clomid challenge tests when I was early in my career.
Man, you guys are making me feel really old. Let me just point out for coldest and TCs, I never did one of those. Those are on the internet too. Those are for ectopic pregnancies though. But
so Carrie, did you ever do Clomid challenge tests like in fellowship or anything?
No, I read about them a lot.
Get out. Okay. Now I feel really old, Carrie. You never did a Clomid challenge test? No kidding. Wow.
No, I've never actually done one. I think maybe once in residency, but even then, I don't think so.
Mm.
I'm not that much younger than you guys, but I think
Yeah, you are.
clicking point in here where I actually don't know I know what they are. I just have never done most of these guys.
We did them like when I first got into practice for the first couple years. And around that time is when like AMH testing kind of came out to help support FSH and estradiol testing. So first of all, before I get into it, it's part of an ovarian reserve testing profile. So none of the ovarian reserve testing is perfect. And so most of us do multiple tests and put them all together and be like, okay, we're looking at quality and quantity, and this is giving us kind of a big picture. Okay. And so that's kind of where the Clomid challenge test came from. So it started out as that day 3 FSH and estradiol level, okay, to see how the brain and ovaries are talking to each other. Well, after you would do that, you would do 5 days of Clomid. I think it was at 100 milligrams, if I remember correctly. Like I said, I haven't done this in a number of years. And then you would repeat the FSH and estradiol around day 10, if I remember correctly. And essentially, you should have relatively similar findings in both of those numbers. But like I said, it didn't really have a lot of strength beyond your day 3 FSH and estradiol. And when AMH came along, I think we kind of switched to FSH and estradiol gives us a little more information about quality. AMH gives us more information about quantity. You can throw in an antral follicle count, which is the ultrasound where we're looking at the number of follicles on the ovaries. Between those 3 tests, you have something pretty good, and you avoid having to have somebody take Clomid, which a lot of people don't tolerate well, and you avoided another blood draw. And who really wants another blood draw? So
yeah, I mean, we kind of said back in the day, it was kind of like a stress test for your heart. You do an FSH kind of baseline, and then you stress your ovaries with the Clomid and then repeat the number and see if it was basically the same, like you were saying, Susan. And, it did pick up people that had really bad FSH levels, but it was that's kind of like catching somebody right before they have a heart attack or something. If you had a really bad FSH, it was kind of beyond the point where, our treatments would be helpful. It was more like a situation where that patient probably needed to go to donor egg or donor embryo. And like you said, sometimes you do it on younger patients and they get really hyperstimulated on Clomid. So it didn't work very well. AMH is much better now because we can do it at a time when you're not stimulated at all. We just draw your blood when you come to the office.
I have seen some practices use it as exclusionary criteria. If a patient has X value, they won't take them. But I don't know that really adds a whole heck of a lot. And at least for the 3 of us, I don't think any of the 3 of us have exclusion criteria where if you have X value, we just will flat out refuse to do it.
There used to be insurance policies that required a Clomid challenge test. And I think most insurances have, especially over probably the last 5 years. I do some insurance reviews, so I kind of see what's coming through and what gets, through the appeals process. And I think those criteria are pretty much going by the wayside because the data just really doesn't support that it's a very valuable test.
But I know in our patients, though, they need day 3 values.
Right.
I tell the patients it doesn't really help us, but there again, if you have a day 3 FSH and it's really high, that's not good news. I mean, probably not many of the treatments that we have are going to be very helpful if you have a really abnormal FSH on day 3.
Exactly.
Who wants to take sperm penetration?
Go for it, Abby.
All right. So this kind of goes back to, the idea that if the sperm isn't perfectly shaped, so if the head's too big or the tail's too crooked, the concern is, can the sperm swim to the egg? Can the sperm bind to and penetrate the egg? And so we still, there's still potentially factors, because we know that there's receptors on the sperm head and on the egg, but clinically we don't have a great test for them. So the idea behind the sperm penetration assay was, can we mimic a situation in the lab that's similar to what the sperm would go through when they were in the woman's body? And so we would take hamster eggs because hamsters have the same sort of construction of the egg. They have the same sort of like barrier that the human egg has. So you would mix sperm in a lab with hamster eggs and see how well the sperm penetrated. And so the idea was if they penetrated well, that even if the shape of the sperm or the morphology was not very good, it probably was not significant. And so Now we know it's a pretty much useless test. It doesn't really tell us a whole lot, because I'll tell you, more than one time I would call somebody to tell them that the SPA, sperm penetration assay, was abnormal. And they'd be like, oh, I just had a positive pregnancy test today. So it wasn't the most useful test. And so therefore no one uses it anymore. So
did you order these from a lab and have them shipped in? And how exactly do we go about getting hamster eggs?
I want to know who's doing hamster IVF. That's what I want to know.
I mean, people, believe it or not, when I interviewed for fellowship, there were places that literally had their own hamsters, and they would harvest the hamster eggs and use them. But you could order them. You could order them from labs, and I think you probably still can somewhere.
Can you imagine that tiny little ultrasound probe to get, whether it's an abdominal ultrasound or, I assume hamsters have vaginas. Why they're mammals? Why wouldn't they? But can you imagine that probe to get those eggs?
Husbands would also, laugh when, if they had a good SPA test, they'd be like, well, at least I can knock a hamster up. So that's good.
All right. So next one, we talked about sperm penetration and sperm antibodies. Next one's ovarian antibodies. This is one that it's a blood test. It's easy to get, but again, there's not a whole lot we're going to do about it, because
why would you get it, Carrie? Why would anybody want an ovarian antibody test?
This one tends to come up more with premature ovarian insufficiency or failure. And the thought is that there's an autoimmune condition, because we do see women who have more autoimmune conditions are a bit more likely to have these ovarian insufficiency syndromes. And it's one of those things where you can get it, but it doesn't change anything. There's no steroids that we can give that change anything. There's nothing different that we're going to do. And many physicians, particularly in an insurance era, and even just good clinical medicine, is you don't order the test that's not going to have any impact on what you're doing. Mm-hmm. And so with ovarian antibodies, it doesn't change anything. And so getting it doesn't really make a whole lot of difference. And I think sometimes patients may feel a little bit better, but just knowing, my antibody levels are high, but we can't even necessarily say, they're high, therefore that is the reason why you have ovarian insufficiency. So next up on the list is testing for blood clotting disorders in recurrent pregnancy loss in particular. MTHFR, methyl tetrahydrofolate reductase deficiency, also falls in this category. So who wants to jump on this monster?
I'll kind of talk about this a little bit. So this is one of those kind of gray zones that not everybody practices the same way. Okay. But realize that, first of all, the blood clotting disorder that has the strongest evidence in first trimester miscarriages, which are most of the miscarriages that people experience, is going to be a condition called antiphospholipid antibody syndrome. And that's an acquired blood clotting condition. We do a blood test, see if you have some positive markers. If it is positive, because some of these markers can be transiently positive, we repeat those labs in 12 weeks to make sure they're truly real. Because if they are truly real, we are essentially sentencing you to being on injectable blood thinners and aspirin throughout your entire pregnancy and 6 weeks postpartum. So it's a big deal. We don't want to just toss these medications around to just anybody. Now, the strongest evidence says that the other blood clotting disorders, if there's a role in pregnancy, they are more likely to have a role in probably second and third trimester miscarriages. And so even I know amongst the three of us, some of us do some of these blood clotting tests in first trimester losses, some of us don't. But as patients, you should probably realize that if you get them for first trimester losses, sometimes your insurance company may not cover them because there isn't a lot of strong evidence. It doesn't mean we can't order it. It's just there's not a lot of strong evidence, but if you have, a family history of somebody with a blood clot, or especially a personal history of a blood clot, but I'm assuming usually if you've already had a personal history, somebody's already run these labs on you, or they should have. And so that's kind of where blood clotting disorders kind of fall into. Do y'all have any other kind of words about that?
I would say that the one that I probably see the most often is someone comes in and says, I have MTHFR. and there's 2 different variants of MTHFR. And the important thing to know about that is it's a deficiency in how the body processes folate. And so we always tell people take a more bioavailable folic acid.
Which would be what, Carrie?
I knew you were going to ask me that, and it just flew out of the L-folate.
Yeah.
And so, cheap, easy intervention. You got to take folic acid anyway in pregnancy, so no big deal there. But about 40% of the world walks around with an MTHFR mutation, and 40% of the world is not having problems.
And definitely not needed to treat those patients with Lovenox for sure.
Yes. And so like Susan said, these are big medications that are powerful, and they are wonderful when used in the right population, but we want to make sure we are not giving them out willy-nilly because there's some potentially very significant side effects that you can have from them. So we want to be judicious in who we're using them in. So, all right. And then the last test on our list is cultocentesis. And Abby, this is all yours.
Just the reason I threw that in there, even I haven't done this one, but this was a test a long time ago. If somebody had a ruptured ectopic pregnancy, you could actually put a needle in the back of the vagina, in a little opening there, and if you aspirated blood, then that made you worry that they had a ruptured ectopic pregnancy. Now, the good news is we have ultrasound that's pretty good at looking for those sorts of things. So, but that's just something still that comes up every now and then. I've had patients ask about that, particularly a patient that were worried about an ectopic pregnancy. So I always say the longer I stay in this field, the less tests there are. There are a lot more tests when I started out than there are right now.
And things seem to cycle every so often. Like I know for a while, just a couple of years ago, I was hearing about intralipid and IVIG all the time. And when I went back to look at the data, I was like, oh, this is all from the 90s. And they didn't have any data for it then. And I haven't seen any great data for it now. I don't know if you guys have.
No.
Things seem to cycle. And so every so often you'll be like, oh, I read about that in the history section of my REI textbook, and now it's back. And
I just thought of one other thing as you're talking, Carrie, for a luteal phase defect now, which means that you don't make enough progesterone in the second half of your cycle. Now we know that it's probably reasonable to check your progesterone, probably just once. But if when the first paper came out, it looked at checking progesterone 3 or 4 times in the same luteal phase and averaging it. But now we know probably checking it once is okay. But there are tests there were times where we would actually do a biopsy of the endometrium at that time and look at it and date the endometrium based on how it looks. So we'd take a sampling of the lining, but now we know that it's probably not that helpful, and it's probably just as easy just to give you some extra progesterone. It's like Carrie says, it's like dumping water in the ocean to get a little extra progesterone if we're worried about it.
Yeah. So, all right. Well, lovely. Well, I am so glad that I get to see you ladies today. And to our audience, thank you so much for listening. We are always grateful that you are here with us, hanging out with us. Be sure to subscribe, leave us a review in iTunes. We would love to hear from you.
You can also visit fertilitydocsuncensored.com to schedule an appointment with any of us or submit specific questions you have about infertility. All questions will be answered on the podcast anonymously for our Ask the Doc segment, so don't hold back. We also love great ideas for our podcast as well. Let us know what your thoughts are.
All right. We'll talk to you soon.
Bye.
Bye, everybody.
Bye.